different subjects for pharmacy practice, like pharmacy practice subjects are having, and evidence-based medicine, pharmacoepidemiology. So those are the topics I'm teaching currently here. And if you ask me what are my favorite subjects, I can say right away the pharmacoepidemiology. That's what the first thing I have taken. Even I was not knowing much before I start teaching this pharmacoepidemiology for PharmD. Because I need to teach, I learned many things. And while teaching to the students, for PharmD students, I gained so much concept in the area of pharmacoepidemiology, and also sometimes and somewhat about pharmacoeconomics as well. So those are the two things I learned on my own, because I was having some background understanding about systematic reviews and some biostatistics as well, because some basic understanding is very much required to understand pharmacoepidemiology. I know maybe your teachers are teaching you pharmacoepidemiology. They may be saying, as Dr. Karthik mentioned, it is a dry subject. It's a dry subject. I understand that. But if you understand the concept, that's going to be, I think it will be there with you for a long time. If you study the concept wise, if you can understand the concept, so that will be there with you for a long time, not only till completing your examination. That's what I used to teach even for my students. I don't teach them to write for the exam. I will teach them to, the concept should be there with them for a longer time. That's what the way I used to teach them, especially pharmacoepidemiology. Let's see how best maybe I can share with you some of the new concepts, or maybe the existing one, how best I can share with you the understanding way, the pharmacoepidemiology concepts in this lecture for 1 hour. And I think nothing much. Maybe you could have read about me, or
Yeah, I will do that, sir.
yeah,
So, so general, I go with like informal way of introducing and connect more.
yes, that's much better
So
actually.
I met sir like once in Nellore and maybe in Bangalore, probably at other place. So some people are so warm, like we don't hesitate to approach them and talk to them. So Krishna sir is one such person. And today afternoon when I made a call, so I was so happy talking to him. We chatted many times, and we have some mutual connections. Like sir spent some time with Vidya Niketan College, and the principal ma'am knows both of us. So whenever I talk with that madam, we talk for a minute or two about you, seeing your progress and the way you are helping students. So as sir was saying, he got awarded with PhD and then moved to Naipur in Guwahati. So he teaches subjects like pharmacoepidemiology, pharmacoeconomics, pharmacovigilance, pharmacotherapy, evidence-based medicine, the core subjects of PharmD. Though sir has not did PharmD, he did everything, B Pharm, M Pharm and all, but he gained enough expertise and teaching students of PharmD in these areas. And he's also involved in research, specifically in medication safety in special populations, MTM in cardiology, and evidence synthesis. So again, sir has expertise in conducting various pharmacoepidemiological studies in hospital and community setting. And when I read this, I was thinking if we can take his guidance and do this kind of a project during 5th year or even in 6th year. So sir has received various grants like 2015 Endeavour Executive Fellowship from Department of Education, Government of Australia, to take 3 months training in advanced pharmacoepidemiology and quality use of medicine. So sir, during your talk, I want you to throw little light on this achievement also, how you got the fellowship and your experience at Australia.
Yeah.
And he received travel grants from ISP, which is the International Society of Pharmacoepidemiology, almost every year from 2013. Hong Kong, Taiwan, Thailand, USA, Australia, China, Japan, Korea, as a speaker in the prestigious conferences. And he also received a travel grant from ISPAR to attend ISPAR held in Austria in 2016. And as I said, sir has expertise in systematic review and meta-analysis and published various articles cited very well. And one of them was Statin Use and Risk of Parkinson's at 20th World Congress on Parkinson Disease and Related Disorders held at Switzerland. So currently there are like 70 plus scientific publications to his credit, and total citations are close to 1,000 in very high index journals. And sir has done more than 120 guest lectures at various national and international conferences, specifically in areas of pharmacoepidemiology, vigilance, economics, clinical pharmacy, systematic review, and meta-analysis. And Sir, I think I saw this on LinkedIn. Sir is currently leader of International Society of Pharmacovigilance, South Asian chapter, member of again ISOP, Medication Errors Special Interest Group, member of International Society for Pharmacoepidemiology, International Society for Pharmacoeconomics and Outcome Research, ISPAR, I think most of you are aware. Cochrane, American Association of College of Pharmacy, Indian Pharmaceutical Association, and sir is also coordinator for Adverse Drug Reaction Monitoring Center set up at Naipur, Guwahati. So with this introduction, I welcome you, sir. So we are also live
Thank
on
you.
YouTube. You can take over from here.
Thank you. Thank you very much, Dr. Karthik, for that kind introduction. I'm very glad for that. And thank you for inviting me to interact with the young family students. I always cherish to talk to them in various platforms. And thanks to all the audience who joined here, I think more than 150 numbers. And I always used to see Dr. Karthik activities. It is not maybe sharing the experience. And I used to see many activities being a PharmD graduate and to do something for PharmD student. That's what his passion. And that's what he's doing from many years. I used to see him in various occasions. And where I think every time he used to see what benefit, what thing he can do for PharmD. So I think in that way he started this startup and then giving you all the lectures, bringing the experts from different areas and giving you some experience, right? Even though during this pandemic, that's very, very important. I think he's going to give you something what you are not getting from your college, the regular college. From regular college, you're going to get so many things like your practicals, your subjects, everything. But I don't think so you're getting this kind of expertise during your regular classes. So that's what he's giving. He want to give you an additional thing. And I would like to follow maybe from now onwards all the activities of especially this Avenida, whatever the activities which are going on. And today, what we are going to be discussing is about the pharmacoepidemiology. Some of you maybe in fourth year who are going to study next year the subject pharmacoepidemiology, and some of you maybe in fifth year you are already started studying, and some of you are maybe in sixth year who already completed the subject and written your examination. And I'm sure that you forgot maybe the concepts also. And today what I'm going to do is giving you some extra information, maybe what you did not study during your course of pharmacoepidemiology, and in a concept way, not in a theoretical way, tell you about what this is cohort study, this is what is going to be happen. I would like to give you some concept, like if you want to say pharmacoepidemiology, you should be knowing what is meant by pharmacoepidemiology first, and what all the study designs usually comes under pharmacoepidemiology, and how exactly we need to conduct those studies, right? When you come to sixth year or fifth year, you need to conduct some studies by taking the patients, and what kind of study design you need to follow for doing a certain kind of study, right? And if you know that, you can do a better study and you can come out with the better findings. That's what is going to be happen always. And Dr. Karthik mentioned I received various travel grants, especially from ISPI. So ISPI is one of the society where I'm connected from 2012 and connected till now even, and a very important society for pharmacoepidemiology, International Society for Pharmacoepidemiology. And they used to conduct various conferences every year. One is going to be the international, usually it's going to be happen in USA, and one is going to be the European one, and one will be in Asia every year. It is going to be, one conference is going to be in Asia. And 2012 in India, we have conducted first time by JSS College of Pharmacy in Bangalore. And from that point of onwards, I'm attending all ACPE conferences, Asian conferences on pharmacoepidemiology. And last year it held on in Korea. Actually, virtually it happened. And this year it's going to be happen in Taiwan. So if you're interested in pharmacoepidemiology, one thing certainly you need to do is follow the activities of this international organization on pharmacoepidemiology, ISPI. And you are going to get many other things, not only conferences. They're going to give you various guidelines for conducting this pharmacoepidemiological studies. And they're going to have some mentorship program where you can identify any mentor who can provide you some suggestions and who can guide you virtually on various topics of pharmacoepidemiology, right? Maybe you can follow that. And most importantly, it is not that all these conferences I've attended by spending money from my side. I don't have enough money. So I used to get travel grants. Not only me, many people from India, they used to attend these conferences by getting the travel grant from the society. They are going to be provide you everything. You don't need to spend a single rupee from your side, starting from your travel, your accommodation, your flight tickets, everything. If you apply for travel grant, first you need to send your abstract. If you did any research in the area of pharmacoepidemiology, you need to send the abstract to them. Once the abstract got accepted, you can apply for the travel grant. And that, I think, when you are applying, you need to send one letter of intent why you want to apply for the travel grant. If your letter is strong and your abstract is good, you're going to get the travel grant. And with that travel grant sufficiently, you can go and come back easily with that money, whatever the money they're going to be provide you. So like that, I used to attend the conferences of this ISP every year. So you can also try. I have seen many PharmD students used to attend that. Maybe if you don't know about this, you can try now. Maybe after this class, you can go and type ISP and then try to see various activities which are going on about the ISP. And I used to tell every time, being a pharmacy practice person and teaching for PharmD students and pharmacy practice students, you studied many subjects like pharmacology, pharmacognosy, uh, and pharmaceutics, and maybe pharmaceutical analysis. You studied many subjects, right? But being a pharmacy students, the three advanced subjects you need to study, and you need to keep that with you for longer time. Maybe chemistry analysis, whatever we studied in the first year, second year, we may forget by the time we come to sixth year or fifth year, right? But these are the subjects you should be having the concepts and understanding throughout your life, being a pharmacy student or being a pharmacy practice students. Those three subjects are the three pharmacos are there, which I like personally: the pharmacoepidemiology, pharmacoeconomics, and pharmacovigilance. Means if you want to differentiate yourself from other pharmacy courses or other pharmacy students like B Pharmacy or maybe M Pharmacy, you should be an expert in all the three subjects, all these three pharmacos: epidemiology, economics, and pharmacovigilance. And for all these three important subjects, anyway, you're going to be studying theory, and maybe you can learn all these concepts from some other conferences. And more importantly, you need to follow three important societies which are relevant for these three important branches. As I mentioned, pharmacoepidemiology, you have ISP, International Society for Pharmacoepidemiology. And for pharmacoeconomics, already you know, you have ISPOR, ISPOR. You could have attended many conferences of ISPOR already, which are happening in India. International Society for Pharmacoeconomics and Outcomes Research. And there is one more society for pharmacovigilance. That's what ISOP, International Society of Pharmacovigilance, right? These three societies you follow and just see what kind of activities they are doing and try to attend some of these activities so that you can understand what is happening currently throughout the world, not only in India, throughout the world, what is happening in these areas, three important areas, you can understand yourself. And being a PharmD person, one more important thing you should be having the quality is updating yourself. If you're not updating yourself, you are backwarded, right? So you should be updating yourself, especially in terms of medications, in terms of what is happening currently. What is a drug which is approved by DCGA yesterday or maybe today? And what is a WHO guideline released recently on a particular issue? You should be knowing each and everything, right? So for that, I think nowadays nothing is difficult. If you want to understand something, if you want to gain knowledge something, everything is in your hand through your smartphone and through your computer. If you have an internet connection, that is more than sufficient. You can get everything and anything in your hand, right? You don't need to depending upon anyone. You can directly go to YouTube. If you don't know something, you can go to YouTube and try to search for it. You're going to get it very easily, right? The only thing is you should have an enthusiasm and you should have a passion to learn something new. Then you can certainly get it, right? So that's what my initial message before going to the lecture of pharmacoepidemiology. Maybe we can discuss more. And this lecture, I would like to have a discussion mode. I want to have some active participants who want to unmute yourself and speak to me in between, okay? Or maybe even starting. Before I'm going to start my presentation, I have a brief presentation on pharmacoepidemiology. Before I'm going to start, I would like to hear from you what you know about pharmacoepidemiology, basically. Anyone, you can volunteer yourself, we can have a chit chat, and then I want to understand what you may be knowing so that I know what I need to teach in this 1 hour. Okay, so anyone, you can volunteer yourself, you can talk to me, please. Anyone, please. So what you know about pharmacoepidemiology, what you heard about pharmacoepidemiology already? and what is your understanding on this subject?
Good evening,
Hello,
sir.
sir.
Effect of drugs in population.
Study of
Maybe
study
I
of
can select Tejashwini.
Good evening, sir.
Yeah, good evening, Tejashwini.
Effect of drugs studied in populations.
Exactly. So we are going to be study the effects of drugs on human beings, right? That's what you are saying. Means
Yes, sir.
population. One more word maybe we can add for that, so that it may be the proper definition of pharmacoepidemiology. We are going to be study the effects of drugs in a large number of people. That large maybe we can add it, so that the definition is going to be very clear. In pharmacoepidemiology, mainly we need to understand we are going to study the effects of medications in a large number of people. Effects means it may be beneficial effects, it may be side effects, safety issue, or maybe efficacy issue. Anything we are going to be studying, safety and efficacy. Someone typed it. Very nice. That's good. Yeah, Tejashwini. Apart from the definition, to know anything in the area of pharmacoepidemiology. If you feel something is under pharmacoepidemiology, you can discuss.
Sir, it is done in large populations, but it is mostly for assessing the safety of the drug and utilization of drugs for a longer period of time.
Exactly. So why? That's a good thing. That's a good thing to understand. Chemistry. Chemistry. Why you feel in pharmacoepidemiology mainly we are going to be focus the safety. As you know, all of you know the randomized control trials, right? RCTs. Certainly, we need to conduct before the drug is releasing to the market to show mainly the efficacy. In RCTs, mainly we are bothering or mainly we are checking for the efficacy. But in case of pharmacoepidemiology, we are going to be mainly focused on safety. Hemashri, can you please why we are mainly focusing on that safety only?
Sir, actually, these are done on heterogeneous populations. So the effects may be different in different populations. So safety is the main concern when the drugs are used for long period of time. They may show adverse reaction on longer period of usage. So maybe this is
Exactly.
an
Exactly.
thank you.
So that's what we are going to be do in pharmacoepidemiology. How it is different from RCT, randomized controlled trials. Nowadays, so much research is happening on pharmacoepidemiology. If I'm not wrong, in future, the pharmacoepidemiology may play a very important role, even more than randomized controlled trials. That's what is going to be happen in the future. Why? Because in the randomized controlled trials, we are mainly focusing on efficacy. Very rarely we are going to be come out with some safety issues. The moment if you see any randomized control trial article, the moment if you read the title, you don't need to read other parts. You can clearly understand what will be the conclusion. Especially if it's a randomized control trial on a new medication compared to placebo or compared to any other medication, certainly the conclusion is going to be their medication or the newer medication is more efficacious than the existing medication or maybe the placebo. That will be the, I'm sure, if you read maybe 100 RCTs, around 99 RCTs are going to be give the same conclusion. Their medication is efficacious than the existing or maybe the placebo. If you compare to placebo, anything is safe, anything is efficacious, right? So no need to do any study and explain that in detail. So what will happen by saying that they're going to be get the approval and the drug will be available in the market. And now what will happen in RCTs, maximum they're going to be take some 1,000, 2,000, maximum 5,000 people. But when it is released into the market, thousands, lakhs, and crores of people are going to be take that same medication. So what the pharmacoepidemiology will do is, in the pharmacoepidemiology, anyway, the efficacy is already clearly described and already clearly studied. So we know that this medication is efficacious. But by using pharmacoepidemiology, what we need to focus is we need to focus on safety. What are the new adverse drug reactions the patients are going to be get, as Manishri mentioned, for after taking the longer time, right? So if the person is taking the medication for 20 years, what are the side effects the person is getting, which are not identified during the clinical trials? Many side effects, many adverse drug reactions we are not going to be identified during the clinical trials. And that's what we are going to be aiming for when we come to the pharmacoepidemiology. And meanwhile, what will happen, don't feel that the pharmacoepidemiology can identify only safety. That's going to be the disadvantage for the companies, disadvantage for the manufacturers. Sometimes that's going to be the advantage for the manufacturers. What will happen when they're doing these studies, they're going to be identify one side effect. Sometimes that may be the beneficial effect, And with that indication, the drugs may be there maybe for longer time. Can anyone give me any example like that, where they have identified a side effect, but that become an indication, and now the people are using that medication only for that purpose?
So minoxidil.
Sildenafil.
Thalidomide.
Yes,
Sildenafil.
minoxidil, we have many examples, right? So minoxidil, as you know, it released for hypertension, but nowadays no one is using minoxidil for that purpose. Everyone is using for hair fall, right? And sildenafil released for some other indication for portal hypertension, but nowadays no one is using for that. They're using as a aphrodisiac, means increasing the potency. So that's what is going to be happen, right? You no need to bother. You can study further. If you study further, you can get more and more indications for that medication, and that can be available in the market for longer time. That's what happened for even aspirin. Aspirin was there from long time, even from more than 100 years. It was initially we are using as an NSAID, but now no one is using as an NSAID. Everyone is started using the as an antiplatelet agent, because you study more by using pharmacoepidemiology. You study more about that medication. Don't leave that molecule. Study about that molecule further and further. So one day you can get more indications for that, and that maybe save your medication for being there in the market for longer time. That's what is going to be happen. That much important the pharmacoepidemiology is going to be once the drug is releasing into the market. That's good. Thank you everyone for participating, and I would like to hear from you, like what kind of study designs we are having in pharmacoepidemiology. Hope you hear the study designs under pharmacoepidemiology.
Cohort studies, cross-sectional case control, meta-analysis.
Okay, that's good.
Randomized control studies. Randomized control studies.
Okay,
Observational experimental.
exactly. So we can majorly divide them into observational and experimental, and those two usually comes under the analytical study designs. Okay. And moreover, we are going to have descriptive. I can show in my presentation, but mostly you hear at least few study designs under pharmacoepidemiology: cohort study, case control study, and cross-sectional study comes under observational. We are going to just observe. And one more important one comes under experimental is a randomized control trial, where we are going to be provide some intervention. That's why we can call it as an experimental study design. We are doing some experiment to identify the effects of medication. Okay. So one last question before going to share my presentation. What is the difference between a cohort study and a case control study?
Cohort
Anyone?
studies are for long time, sir.
Okay. And case controls.
Sir, case control study, there will be a comparison.
Yeah, Krishna, please.
Yes, sir. In case control study, there will be a comparison group.
Okay.
In cohort study, there will be no comparison group, sir.
Actually, comparison group should be there in both the study designs. Without comparison, there is no conclusion. In all the study designs, whatever I mentioned, cohort, case control, cross-sectional, randomized control trial, comparison should be there. That means if you want to say A is better compared to what? Compared to B.
In case
Certainly,
control study,
there should be.
we will
Case control is a
assess the
prospective
outcomes
study, whereas
and looking forward backward for the reasons. In the case control study, in cohort study, we will study the causes
These are
and
retrospective
we
studies.
look forward for the outcomes.
Exactly. I think very brief. I think Meghana mentioned very briefly whatever you explained, Mahananda. Whatever you explained, one word is there to explain all those things. We have one simple word: prospective, retrospective. Very simple words. Prospective means going forward. Retrospective means going backward. In a cohort study, mostly we'll go from prospective. That means we are going forward. From today, we are going into the future. In case of case control study, we are going backward. From today, we are going back and try to understand what happened maybe in the past 5 years back or 10 years back. So prospective and retrospective, we can easily understand for the cohort study and case control study. Okay, let us see what I'm having in my presentation, and then we can have more discussion. I can quickly maybe run through the slides and also explain wherever it's required in detail. And finally, we can come once again for the discussion. Okay. So this is what I was mentioning. One simple thing you should be understanding before going further about pharmacoepidemiology is what kind of study designs you are having. Mostly all the study designs, we can divide them into prospective and retrospective. It's very simple way of understanding. Always we are going to the future, right? Every minute is going to be calculated here. So we are going into the time, into the future always, right? And in case of pharmacoepidemiology, there are two important terms we need to understand. One is the exposure, another one is an outcome. Exposure should be there, outcome should be there. And for understanding purpose, for easy way of understanding purpose, I think everyone knows that example, the smoking and COPD. That's what the example we are discussing from long time, right? So in that smoking and COPD, smoking is going to be the exposure and COPD is going to be the outcome. And first you understand about the smoking. That means you have two groups, one group of smokers, another group of non-smokers. And then you can follow them over a period of time, maybe for 5 years. And then try to understand after 5 years, among the smokers, how many got the outcome and how many did not get the outcome. It is not that all the smokers are going to get the COPD. Some may get and some may not get. And also it is not that all the non-smokers are not going to get the COPD. Some may get and some may not get. Okay. So you are having two groups, smokers and non-smokers. And then you are following them over a period of time and then try to understand how many got the outcome in both the groups. That means we are going into the future. That means we are following them over a period of time, maybe for 5 years, and then try to understand the outcome. Initially, we are having the exposure. At the end of the follow-up, we are going to get the information on outcome. How many got the outcome and how many did not get. So we are going into the future. From exposure, we are going into the outcome. And that's what we call it as a prospective. Prospective means always going forward. We are going from the exposure to the outcome. And what is meant by retrospective is the case control study comes under retrospective and cohort study comes under the prospective usually. But always we think that cohort study means prospective. I can explain to you today, cohort means it is not always prospective. Cohort means sometimes it can be retrospective also. But mostly it is prospective, but sometimes it can be retrospective as well. I'll explain to you how exactly it will be. And here what will happen in case of case control study, first we are going to have the information on the outcome. We are going to take two groups. One group is COPD group, another one is a non-COPD, people who are not have the COPD. So what we are going to do is we are going to be understand about their past history. We are going back and inquiring about their exposure status, past history about the smoking. Among the COPD patients, how many are already smokers and how many are non-smokers? Among the non-COPD group, how many are smokers and how many are non-smokers? So first we are having the information on the outcome, and then we are going backward and then try to understand about their exposure status. That means we are going backward, we are going back into the time, we are going into the past. That's what is called as a retrospective study. Very simple way of understanding the pharmacoepidemiology, prospective and retrospective. If you go from exposure to the outcome, prospective. If you go from the outcome to the exposure, it's a retrospective. Going forward, going backward. Very simple way of understanding the pharmacoepidemiology. Okay. And let us see the definition. All of you studied your pharmacology and you know what is the definition of pharmacology. That is a study of the effects of drugs. Where? By using animals, right? And if you add clinical to that pharmacology, that's what is called as clinical pharmacology, the branch of pharmacology. Wherever you add the term clinical, that means always it is describing about the human beings. Clinical means human beings. Clinical pharmacology, we are doing the same thing what we are doing for pharmacology, study the effects of medications only. But only thing is we are studying the effects of medications by using the human beings. That's what is called as the clinical pharmacology. If you see one more important branch, the definition, that's what is epidemiology. That is a study of distribution and the determinants of disease in population, like how the COVID is distributed and how exactly it is, maybe what are the factors responsible for that. If you want to study, that's what is called as the epidemiology, for understanding about a particular disease in a population, right? And if you combine these two branches like clinical pharmacology and epidemiology, you're going to get the definition of pharmacoepidemiology. So the pharmacoepidemiology, the definition is, it is a study of the use and effects of medications in a large number of people. That's what is a definition of pharmacoepidemiology. It is a combination of two important definitions, clinical pharmacology and epidemiology. So from the clinical pharmacology, it is going to take the focus of inquiry, where exactly we need to focus. And from the epidemiology, it's going to be take the method of inquiry, which method we need to follow for understanding the uses and effects of medications. And in the uses and effects, we are going to be understand both the side effects as well as the beneficial effects. By using pharmacoepidemiology, we can understand anything. And all of you know the various phases of clinical trials, right? You know, phase 1, phase 2, phase 3, and finally phase 4. Phase 4 is a post-marketing surveillance studies. So whatever we are doing in the pharmacology, it can comes usually under preclinical studies because we are doing the studies on animals. And whatever studies we are conducting under the clinical pharmacology, they comes under the clinical trials, the clinical studies, because we are conducting on the human beings. So all the phase 1, phase 2, phase 3 comes under the clinical pharmacology, where we are testing the medication by using the human beings. And now the phase 4 comes into the pharmacoepidemiology. That means pharmacoepidemiology comes into the role after the drug is releasing into the market, after conducting all these studies, randomized control trials. Once the drug is releasing into the market, the pharmacoepidemiology is going to be comes into the picture. And now we are going to be take up the people who are receiving that medication, and we are going to be follow them over a period of time, usually for a longer period of time, by taking the large number of people and try to understand the effects of the medication, the new effects in the sense, the effects which we did not identify during the clinical trials. Those effects we want to understand by using the pharmacoepidemiology. And all the pharmacoepidemiological studies comes under the phase 4 studies, the post-marketing surveillance studies. Okay, that's what the definition of pharmacoepidemiology. And this skeleton is very important for you to understand various study designs comes under the pharmacoepidemiology. And basically, we can divide them mainly into two types: descriptive, analytical. Very simple way of differentiating various study designs comes under the pharmacoepidemiology, the descriptive and analytical. Under the descriptive, we are going to have two important examples: survey, cross-sectional, we can also call it as, and the qualitative. Under the qualitative, we have two important examples: case reports and case series. Okay. So what will happen here in the descriptive is we are going to be just describe. We are not going to be perform any analysis. We are not going to be have any control group here. We are going to be have only the population and then outcome. So if you want to understand how the COVID is distributed throughout India, right? We are going to be have only two things here: the population from India, and the outcome is going to be the COVID-19. We want to understand how exactly COVID-19 distributed, or what are the factors responsible for COVID-19 in India, right? We are going to be study about that COVID-19. And that's what comes under the descriptive. We are not performing any analysis, and we don't have any control group, something like that. We are going to just describe about the population and outcome. And that's what is going to be happen usually in the survey. Survey, we can also call it as a cross-sectional. The survey, the meaning is we are going to be collect the data only at single point of time. Hope you maybe heard or maybe you are participated in various surveys, especially the population survey. The people come to the home and they will get all the information about people who are living in that home, 5 people or 6 people, and what is the age, what is the gender, and what are the conditions they're having, medical conditions. All those information they're going to be get. How many times? They're going to be get only one time. They'll come, they'll get all the data, they will go. That's it. They don't come back again and again to collect more information, right? So they're going to come at one point of time, collect all the data. So whenever you do any study where you are collecting the data only one time from a patient, that's what is called as cross-sectional. Very simple way, one-time data collection. And survey is one of the important example comes under the cross-sectional. And under the qualitative, you may be knowing case report and case series. If any new event happen in a single patient, when you go to the hospital, when you go your rounds, and you identified that one patient got something new, which was not identified earlier. So you can describe about that patient and you can go for publication. We can call it as a case report. A single patient, something happened new, so you can call it as a case report. And if the same thing happened for 10 patients in the same hospital in a period of 1 year, if you combine all the 10 patients information and go for a publication, we can call it as a case series. The same event happened for a group of patients. You are combining all of them and going for writing a report. We can call it as a case series. Okay. So that's what we are in the descriptive study designs. And coming to the analytical. So in the name itself, we have a meaning. We are going to be perform some analysis here. We are going to do some analysis here. And another analytical, as we discussed already, we have two important study designs: experimental and observational, right? Another experimental, because we are doing the experiment, we are trying to understand about the effect of a new medication compared to the existing one or maybe the placebo. And the example comes under that is a randomized control trial. Another observational, already we discussed, we have three important study designs: cohort study, case control study, and the cross-sectional study. These three are observational study designs, comes under the observational analytical. I'll explain to you the difference between these three in detail in the next slide. So we have some more things here: the question number 1, question number 2, and question number 3. The question number 1 is based on the question number 1. We can divide all the studies into two types: descriptive and analytical. The question number 1 here, it is, what is the purpose of study? If the purpose of study is only describing, we are going to be conduct any of the descriptive study. If the purpose of study is to analyze something and try to see that which is influencing what, or maybe you want to understand the difference between exposure and the outcome, or you want to compare between drug A versus drug B, right? Always we need to do some analysis and then come out with outcome. And all those studies mainly comes under the analytical. So here we are going to have 4 characteristics. Here we are having only 2, population and outcome. But here we are going to have 4. Along with the population and outcome, we are going to have 2 more factors: intervention and comparison. As I mentioned, without intervention, without comparison, that should not be analytical study. Comparison should be there. So compared to this one, we are saying intervention is better, right? So PICO, hope you hear the PICO: population, intervention, comparison, and outcome. And intervention usually comes under the experimental. It is not going to be comes under the observational. That's the reason we have replaced I with the E. So here the E indicates exposure: population, exposure, comparison, and outcome. So exposure will be there in case of observational. Intervention will be there in case of experimental study designs. Okay. So now can anyone tell me what's the question number 2 here? The question number 2 is dividing all the analytical studies into 2 different types: experimental and observational. So what may be the question number 2? Anyone? What may be the question number 2, which is dividing the analytical studies into experimental and observational? Can anyone answer? Please be interactive in between also, so that we can discuss more.
Based on exposure.
Based on exposure. And maybe the question number 2, like, are you giving any intervention? If it is yes, it is experimental. If you're not giving an intervention, you are just observing the patient for a longer period of time. The patient already taking some medication or patient already exposed to something. We are going to be just follow and see what is happening to the patient in the future. We are just observing the patient. So that comes under the observational study design. Okay. And the question number 3 here, it is, as I mentioned, in case of cohort, case control, cross-sectional, we are going to have 2 things: exposure and outcome. So when you are measuring the exposure, when you are measuring the outcome, if you measure the exposure first and then outcome, it is going to be cohort study. First exposure and then outcome, cohort study. First you measure the outcome and then go for exposure. It is a retrospective. First outcome and then exposure, retrospective. It is going to be case control study. And measure all the information at one point of time. Like you are taking all the information on exposure, outcome, any other information you are taking at one point of time. That's going to be the cross-sectional. Okay. So cross-sectional, there is no directionality here. It is not a prospective. It is not retrospective. It is one point of time. And cohort study usually going to be prospective, and case control study usually going to be retrospective in nature. Okay. Just remember, this slide is going to be very important in terms of pharmacoepidemiology. So one slide is going to be give you all the study designs comes under the pharmacoepidemiology. Okay. And this slide, if you understand this slide, I'm going to give you the confirmation. If you understand this one, that means you understand almost maybe 40 to 50% of all pharmacoepidemiology. 40 to 50% of all pharmacoepidemiology, if you understand this slide well. Okay, just focus on it. And just imagine that we are here now. Okay, we are in 2022 this year. And this one is a past, 2015, and this one is a future. Just imagine 2030. Okay, 2022 where we are now, 2015 past, and 2030 is going to be the future. Okay. And just take the prospective cohort study. Cohort study can be 2 types: prospective and retrospective. I'll explain to you how these 2 are different. Cohort means always there's a meaning for cohort. Cohort means group of people. The cohort meaning is a group of people. So we are going to have 2 groups usually. As I mentioned, all the study designs should have two groups, okay, initially. So in case of prospective cohort, you can see how this person is looking. The person is standing here in 2022, looking forward, looking into the future, right? That's what he's doing. And initially, we are going to have two groups, risk factor positive and risk factor negative. That means maybe the smokers and non-smokers, right? And both the groups we are going to be follow over a period of time, maybe till 2030. And in 2030, we are going to be understand among the risk factor positive group, how many got the outcome and how many did not get the outcome. That means among the smokers, how many got the outcome and how many did not get the outcome. And at the same time, among the risk factor negative, among the non-smokers, for example, how many got the outcome and how many did not get at the end of follow-up at the time of 2030 in the future. Okay. So we started the study in 2022 with two groups, smokers and non-smokers, who are not having COPD at that point of time in 2022. No one is having COPD at that point of time, and only they're going to be developed in the future during the follow-up. Okay. So we started the study with the two groups, right? And at the end of the study in 2030, how many groups we are having? Can anyone tell me? How many groups we are having at the end of the study in 2030? We started with the two groups, risk factor positive, risk factor negative. After the follow-up of maybe 5 to 10 years, at the end of follow-up, how many groups we are having here?
Two groups.
Four.
Four, sir.
Four groups. Right?
Four.
What are those four? Risk factor positive, outcome positive, risk factor positive, outcome negative, risk factor negative, outcome positive, risk factor negative, and outcome negative, right? So those are the four groups we are going to be having. Just imagine that we have four groups here, okay? So those four groups about the outcome information we are going to be get at the end of follow-up. That's what is called as prospective. Prospective means always going forward, going into the future, and cohort study, okay? And just see now, what about the retrospective cohort study? Cohort study means one thing for sure, you can note it down right now, what are the notebook you are having, or maybe note it down in your mind. Cohort study means always we are going from the risk factor to the outcome. That's for sure. We are going from risk factor to the outcome. It may be prospective, retrospective, whatever it may be. We are going from risk factor to the outcome. And same thing we are doing here. You can see how this person is looking. This person is looking into the past. From 2022, he's looking into the past. And what we are going to do here, it is, we are going, for example, we are going backward till 2015. We are going back to 2015. In the 2015, we are having, just imagine we are having a database of the people. In that database, we have all the information and about 1,000 people. And that 1,000 people in 2015, we are dividing them into two, who are having the risk factor, who are not having the risk factor. Just imagine in 2015, we are dividing all the people who are whose information is there in the database into risk factor positive and risk factor negative. And somewhere in 2020, right? Somewhere in 2020 here, we are going to be understand among this risk factor positive, how many got the outcome and how many did not get the outcome. Means in the duration of 2015 to 2020, between this period, among the risk factor positive, how many got the outcome and how many did not get. Among the risk factor negative, how many got the outcome and how many did not get the outcome. That's what we are going to be understand in case of the retrospective cohort study. So just remember, cohort study means always we are going from the risk factor to the outcome only. Here also risk factor to the outcome only, and here also risk factor to the outcome only. The only difference here it is, in case of prospective cohort study, when we started the study, we have the information only on risk factor. About the outcome, we are going to get the information in the future after follow-up. But here what happened, in case of retrospective cohort study, both the risk factor and outcome already happened. We are starting in 2022, right? So risk factor already happened and the outcome is already happened. Only thing is we are going backward and then coming forward once again from the risk factor to the outcome. And this can be possible when you have a complete database with you where you have the information on the risk factor as well as the outcome. That can be possible. Okay. Otherwise, usually it's not going to be possible. We need to go with a prospective cohort study. Okay. That's what is going to be happen. I'll take the questions at the end, maybe after this slide. So just see now the case control study, how it is different from a retrospective cohort study, because case control study also a retrospective study, right? So what we are doing in the case control study is, once again, from 2022, we are looking backward, we are looking back. And what we are doing here, it is, we are going to be take two groups initially. What are those two groups? The cases and the controls, not the risk factor positive and risk factor negative. At the starting of the study in 2022, we are going to be take two groups of people, the cases and the controls. The cases means who are having the outcome, who are having the COPD. The controls means who are not having the outcome, that is, who are not having the COPD. And what we are doing, we are going past and then try to understand about the exposure or the risk factor. Among the cases, among the COPD, how many are already smokers and how many are non-smokers? Among the controls, how many are smokers and how many are non-smokers? That's what we are going to be understand. In the past, what happened to these two groups, cases and controls. Why it's a case control study? Because we are taking the cases and controls at the starting of the study. We can call it as a case control study. And we are going into the past and try to understand the outcome. And here also, we are starting with the two groups, cases and controls. And at the end, how many groups we are having? 4. That is outcome positive, risk factor positive, outcome positive, risk factor negative, outcome negative, risk factor positive, outcome negative, and risk factor negative. So we are going to have 4 groups once again here in the past about the risk factor status. Okay. So always in all the study designs, we are starting with the 2
Can you
groups.
repeat once again, sir?
Yeah, I'll repeat it. Yeah. So what's going to happen here? We are going to have 2 groups initially, the cases and controls. The cases means who are having the outcome, controls who are not having the outcome, for example, COPD and non-COPD. And in both the groups, what we're going to see is, among the COPD, how many are smokers and how many are non-smokers already. Among the non-COPD cases, how many are smokers and how many are non-smokers. We are going to be understand that. So we are starting with the 2 groups and end with the 4 groups. Okay. We are starting with the outcome and we are going to be get the information on exposure status. And in this case, once again, we are going backward, right? From 2022, we are going backward. That's what we can call it as a retrospective study design. Okay, we are going backward from now onwards. Okay, that's what the difference between a prospective cohort, retrospective cohort, and case control study. You may have some confusion between these two. Usually, that's going to be a question I used to get always. Before I'm getting the question, I'll explain to you once again. The important difference between retrospective cohort and the case control is both are retrospective only. There is no issue. Both are retrospective only. The only difference is in the retrospective cohort, we are going from the risk factor to the outcome. But in case of case control, we are going from the outcome to the risk factor. So what you are taking first is a difference between retrospective cohort and the case control. First, you are taking the information on the risk factor here and then try to understand the outcome. But here, first you are taking the information on the outcome and then try to understand about the risk factor. That's the important difference between retrospective cohort study and the case control study. Hope you understand this. And one more thing we have here, it's a clinical trial. The clinical trial is a randomized control trial. We are once again, we are going to have 2 groups. The person is looking into the future. We are going to have treated and non-treated. Treated means who are given with a new medication. Non-treated means who are given with a existing one or maybe the placebo. And once again, we are going to be follow both the groups. In the future, we are going to be understand how many got the outcome in both the groups. In the treated, how many got the outcome and how many did not get the outcome, what we're expecting. In the non-treated, how many got the outcome and how many did not get the outcome. In the future, maybe around 2030. Okay. It is same like a prospective cohort study only, clinical trial. The only difference is this is observational in nature, where we are going to have the exposure or the risk factor. This one is experimental in nature, where we are going to have the treated patients and non-treated patients. Okay, that's what we are going to have it in case of clinical trial. So now I'm going to take up the questions. So if you have any questions in this, or if you need any information from this, I'm happy to explain once again. Because this is very, very important to understand the concept of pharmacoepidemiology and various study designs. Anyone? Anyone having any questions? Or if it is clear, just tell me, sir, it is clear. At least I can go forward.
It is clear, sir.
It is clear. That's good. That's good. Good to see. So some more, I think the same thing only I want to explain in different way so that no, it will be there in your mind for a longer time. So we are going to understand the cohort study, right? So we are starting the study here, and the time is going like this. Time is going into the future, right? And we are starting the study here. At the starting of the study, at present, we are going to have the study population who are free from the disease. That means we are going to have the study population, the smokers, for example, who are free from the disease. Free from the disease means free from the outcome. If the smokers already having the COPD, there's no meaning in taking those patients and following them for another 5 years if they are already having the COPD. So one thing we need to make sure that when we are taking the study population in a cohort study, they should not be having the outcome what we are expecting in the future. They should not be having the outcome what we are expecting in the future. They should be free from that disease or free from that outcome. And all the study population, we are going to be divide them into risk factor positive and risk factor negative, right? And we are going to be follow them over a period of time into the future. And in the future, we are going to be get the information on among the risk factor positive, how many got the outcome and how many did not get the outcome. And in the risk factor negative also, how many got the outcome and how many did not get the outcome in the future. So at present, when we start the study, we have the information on the risk factor. After following for a certain period of time, in the future, we are going to be get the information on outcome. How many got the outcome and how many did not get the outcome in both the groups. As I mentioned, we are going to be start the study with the 2 groups. At the end of the study, we are going to be have 4 groups. Okay, we are going to be always we need to end with 4 groups. Then only you can able to do some calculations. Then only we can call it as a analytical study that you can understand maybe in the next slide. So what kind of calculations we are going to be perform in case of the cohort study. Okay, and one thing is important to remember: we are going into the future. From the starting of the study, we are going into the future always in case of the cohort study, especially the prospective cohort study. What I explained here, it is a prospective cohort study. Okay, and I'll just give you 2 minutes time. You just note down this table so that we can do some calculations here. It will be interesting for you. Before you can start note it down, I'll just explain what is there here in this slide. So in the left hand side, we are going to have the information on the exposure. We can also call it as intervention or risk factor, or we can also call it as an independent variable. And here I have an example on empagliflozin and placebo. Can anyone tell me what is empagliflozin? If anyone heard about that medication?
Anti-diabetic.
SGLT2 inhibitor.
It is an anti-diabetic medication. That's good. And do you know?
SGLT inhibitor.
Exactly. So it comes under the new class of anti-diabetic medication, SGLT2 inhibitor, sodium glucose co-transporter 2 inhibitor. And can someone tell me like where it's going to be act? I think you know all other anti-diabetics where exactly they're acting. They're acting on GAT, they're acting on pancreas, they're acting on liver, maybe some other areas. So where this class of medications are acting? Yes, GLT2 inhibitors.
On the nephrons.
Nephrons. Yeah, overall, maybe you can say they're acting on kidney. So what they're going to do is they're going to be prevent the reabsorption of the glucose, and they can eliminate the glucose through the urine. So when they eliminate the excess glucose through the urine, they can reduce the blood sugar levels. That's what is going to be happen for the SGLT2 inhibitors. Okay. So what we're doing here, it is we are comparing, we are having empagliflozin. Don't take it as a placebo. You just note it down this one as a other anti-diabetic medication, because usually in case of cohort or observation studies, placebo may not be the comparator. The comparator may be any other medication, any other anti-diabetic medication. Usually in case of experimental, placebo will be there, but in case of observational, we are going to be compared with some other medications. Okay, take it as any other anti-diabetic medication, any other oral anti-diabetic medication. Okay, that's what is there in the left side. And the right side, we are going to have the information on the disease outcome. We can also call it as a dependent variable, because the outcome is going to be depending upon the exposure. We can call it as a dependent variable. And here we are having the information on mycotic infection, genital mycotic infection, positive and negative. Okay, just note down these numbers and then I can explain to you. This one we can call it as a 2x2 table. The 2x2 table is very, very important in case of pharmacoepidemiology, where we can go and perform some calculations. Even though there are many rows and columns here, we can call this a 2 by 2 table because these 4 boxes are very important. Among all, those are all additional. These 4 are very important for calculation purpose. Hope you're done. And so what
Yes,
exactly
sir.
what exactly we are having here, it is, for example, just imagine we are having 2,971 people for this study, okay? And the hypothesis here it is, what is the risk of getting mycotic infections for empagliflozin compared to any other antidiabetic medication, for example, okay? That's a hypothesis. We want to understand the risk of mycotic infections for empagliflozin compared to other antidiabetic medications. And we are taking 2,971 people overall. And out of this, there are 1976 who are receiving empagliflozin exposure group and 995 who are receiving other antidiabetic medications. That's a control group. Exposure group is empagliflozin 1976 and control group is other antidiabetic medications who are taking 995, for example. Okay, and we followed both these groups, exposure group and non-exposure group, over a period of 24 weeks. Okay, 24 weeks we have followed them. At the end of 24 weeks, I'm going to understand out of 1976 who are taking empagliflozin, 117 got mycotic infection and remaining 1859 did not get the mycotic infection. Okay, out of exposure group. Out of 995 in the non-exposure group who are taking other antidiabetics, for example, 15 got mycotic infections and remaining 980 did not get the mycotic infections. Okay, and we have given some coding here: A, B, C, and D. Always exposure group should be top and then control group. Always outcome positive should be first and then outcome negative. That should be standard in case of 2 by 2 table. Okay, then you can give the coding of A, B, C, D. Okay, and this one is A plus B, where total number of people under the exposure group, and this is C plus D, total number of people under the control group. Okay, and this one is A plus C. It's a combination of these two who are having the outcome total, and B plus D, people who are not having the outcome, and 2971 is A plus B plus C plus D, the total number of people in the study. That's what is about the 2 by 2 table. And now, based on this data, can someone tell me what we got it? What's the outcome of it? The hypothesis is empagliflozin having any extra risk of getting mycotic infections compared to other antidiabetic medication? That's the hypothesis. So what is the information we got from this table? Can anyone tell me?
Yes, sir. It got mycotic infections.
So empagliflozin is having more chance of getting the mycotic infections compared to other antidiabetic medications. So how can we tell that? Based on what? On what basis? On what basis we can?
Exposure and outcome.
Positive outcome.
Positive outcome. Okay, we can see that the total number is more here, 117 compared to 15, but we should not blindly depending upon the number only here. Why? Because the total number also is different. The total number is same, you can depending upon this and you can say that here it is more empagliflozin. But what happened? This number is more, that may be the reason this number is more. This number is less, that may be the reason this number is less. So we cannot blindly go with a number and say this group is having more chance of getting mycotic infection. So what is the alternative?
So we can take a ratio of the positive to total
patient. Exactly. So if you want to interpret anything, if you want to get any conclusion out of any calculation, always you need to depending upon the ratio or the percentage. You should not depending upon the original numbers. Original numbers only for calculation. The interpretation should be based on the percentage or the ratio. And if you calculate the ratio, can someone quickly calculate and tell me what is the ratio for empagliflozin and what's the ratio for placebo? It's very simple. 117 divided by 1976 into 100. And 15 divided by 995 into 100. So what's the percentage in empagliflozin group got the mycotic infection? And what percentage?
5.9%. 5% and 1.5%.
5:1.
Exactly how much? 5 only, or any digits?
5.92.
5.92. 5.9. Okay, for example, 5.9 percentage. Okay, 5.9 percentage got outcome in the empirical frozen, and in the placebo,
1.5, sir.
1.5. So now we can clearly understand 5.9 in the empirical frozen percentage and 1.5 in the placebo group. So there is a clear difference between these two, where the higher percentage of people got the mycotic infections in the empirical frozen compared to placebo. So now it's clear. So we can compare, at least by using the percentage, we can say more percentage here compared to the placebo. But that is not sufficient enough to take the final conclusion. That's the reason when you conduct any cohort study, we are going to be calculate something to get the final conclusion. Anyone knows what we are going to be calculate here in case of a cohort study? Anyone?
Odds ratio or incidence ratio?
Yeah. So odds ratio, actually, we are going to be calculate for the case control study. For a cohort study, if you conduct any cohort study,
Relative risk.
yeah, we are going to be calculate something called relative risk. Okay, there are two things, or actually there are three things. One thing I am not explaining here because it's a complicated one. Relative risk, hazard ratio, odds ratio. One point I'll tell you, just remember throughout your life, for a cohort study or for a prospective study, we are going to be calculate either the relative risk or the hazard ratio. Okay, either the relative risk or the hazard ratio, and mostly relative risk when you have something numbers like this. And for a case control study, we are going to be calculate odds ratio. Odds ratio we are calculating for a case control study or retrospective study. Okay, so we are going to be calculate the relative risk because it's a cohort study, prospective study, and the very simple formula is A by A plus B divided by C by C plus D. Very, very simple formula, not at all difficult to remember further, right? I think you can remember this formula throughout. I think you don't forget after writing your examination. And I don't think so in examination they will ask you all these formulas, especially for pharmacoepidemiology. I have seen many question papers. They don't even ask what is a relative. Maybe sometimes they'll ask what is a relative risk. They don't give this kind of table and then ask you to calculate all these things. Okay. So A by A plus B divided by C by C plus D, very simple formula. And it's not that you should remember only the formula. You should remember what is the meaning of this formula. A by A plus B means incidence proportion in the exposure group. C by C plus D is a incidence proportion in the non-exposure group. Very simple understanding. And whatever you did previously, like how you calculated the percentage, 117 divided by 1976, the same thing you are taking here, A by A plus B, 15 divided by 995, that is C by C plus D. So anyone got any value? How much it is?
3.94.
3.94. Let's see how much I'm having. Relative risk. So 117 divided by 1976, 15 divided by 995, 0.059 divided by 0.015. And finally, I think I have value of 3.93. Okay. So 3.93 is a relative risk value. And if you do the more calculation by using the four values, you're going to be calculate even the 95% confidence interval. And that we got, I'll give you today how to interpret, how to understand all these values. Okay. And we have relative risk of 3.93, 95% confidence interval of 2.31, and it is 6.69. So this one is a lower limit, and this one is an upper limit. And the p-value what we got is a less than 0.001. So can anyone give me? I think before I'm going to explain, can anyone give me what's the conclusion of this study based on this relative risk, confidence interval, and the p-value? Or if anyone heard what I explained previously, maybe in some other lectures. Can anyone tell me what is the conclusion from these values? What we understand from this?
There is a positive correlation association between use of exposure, that is exposure and outcomes. Sir.
Okay. One thing for sure, there's a positive correlation. That means when people are taking the empirical frozen, they have more chance of getting the outcome. That's what is a positive correlation compared to other antidiabetic medication. Okay, that's good. So based on what we can say that, based on which value we can say that positive correlation?
Relative risk greater than 1.
Yeah. So one standard point here it is for understanding this one. Okay, and that's good. Any other? I'll explain to you that one. 95% confidence interval. What you can understand from this one? There is a lower limit 2.31, upper limit is 6.69. What you can understand from this? Okay. I don't hear any response. Okay. What we can understand from this p-value? Less than 0.001. I want to hear from you. Then I can explain to you. If you know already, I'll be very happy. If you don't know already, I'll be much more happy because I can explain to you.
Don't know.
Okay, I'll explain to that. Dr. Karthik, can you please confirm? We have time, right? I can take more time, right? So I can explain to them the concept.
Yeah, yes.
Yeah, sure. So I'll take you this slide. Okay, how to interpret if you get a relative risk, if you get a hazard ratio, or maybe the odds ratio, whatever it may be. Among these three, the interpretation is very, very simple. Maybe people could explain to you previously in a complicated way, but very simple way of understanding any risk measure, maybe the relative risk, maybe the odds ratio, maybe the hazard ratio, along with the 95% confidence interval is, there are some standard points are there. If you cannot remember, you just note it down. The standard points are like, always we are going to have 1. So 1 is a null value, and we are going to have less than 1 and more than 1. Okay. And 1, whenever something falls exactly on 1, that means no association. Whenever the relative risk, odds ratio, hazard ratio, whenever something falls exactly on 1, we can say that there is no association, and the risk of getting the outcome is same for both exposure and non-exposure. Whenever something is less than 1, whenever you get any value less than 1, that means there is a less chance of getting the outcome. Less than 1, less chance of getting the outcome. And more than 1, more chance of getting the outcome. Very simple. Less than 1, less chance. More than 1, more chance. For what? Getting the outcome for exposure group. Okay, always the interpretation should be for the exposure group, the first group what we have taken in the table. And for example, here what we got, 3.9 we got, 3.93, 3.9 we got. 3.9 is more than 1, right? So we can say that there is a more chance of getting the outcome. What's the outcome here? Mycotic infections. For what? For whom? For the exposure group compared to the control group. So the more chance of getting the outcome, how we got? Because it is more than 1. And along with that, we are going to have the confidence interval. It is very important to have this confidence interval to get more information on. We got 3.9, that is more than 1, that's okay. But what about the significance? Whatever the value we got here, is it significant or not? That's what we are going to be understand from the confidence interval. And here the confidence interval, there are two values. One is a lower limit, always it is going to be less than this value. One is the upper limit, always is going to be more than this value. There will be two limits, lower limit and upper limit. They will be on both the sides of the relative risk, hazard ratio, or maybe the odds ratio. Okay. And one layman understanding for this confidence interval is, if you do the same study 100 times, I'm sure that you are not going to get the same value every time, 3.93. You're not going to get it. You may get different values. So at least if you do the study 100 times, 95 times the value will be between 2.3 to 6.6. I'll repeat. If you do the study 100 times, 95 times the value will be between 2.3 to 6.6. The remaining 5 times, it may be more than 6.6. It may be less than 2.3. The remaining 5 times, we are leaving it for chance. Okay. So we are 95% confident that the value will be between 2.3 to 6.6. What happened here? That means we are 95% sure that all the time the value will be more than 1 only, because it is not crossing the 1. The lower limit is not going below 1. And all the times we are 95% sure that the value will be more than 1 only all the times, because it may be between 2.3 to 6.6. We can say that in that case, we can say that whatever value we got here, statistically significant. Okay. Whatever value we got here is statistically significant. Why? Because this value is more than 1, lower limit also more than 1, and upper limit also more than 1. All the times the value will be more than 1 only. So we can say the value is statistically significant. Okay. So how much confident we are here? 95%, right? The 95% we are confident that the value will be between 2.3 to 6.6. What is the remaining percentage? Remaining 5%. Okay. The remaining 5%, whatever it is there, that's for chance. The chance may be like the remaining 5% less than 2.3 or maybe more than 6.6. So what are the remaining 5% we are leaving for chance? If you convert that 5% into the number divided by 100, you're going to get 0.05. So that 0.05 is a standard p-value. So you know that p-value standard is a 0.05. So why the p-value should be always 0.05 means because it is from the confidence interval. We are 95% confident, the remaining 5% for chance. It may be less than this or maybe more than this. What are the 5% remaining is there? That's for the chance. That's what is called as the p-value 0.05. Okay. So in this case, it is significant, and because it is more than 1. Let us see one more example. We have 1.4. 1.4 is more than 1. We can say more chance of getting the outcome. But we cannot say that. Why? Because the confidence interval is found to be not significant. Why it is not significant? One value is going below 1. One value is above 1. If you do the study 100 times, sometimes it is showing less chance of getting the outcome. Sometimes it is showing more chance of getting the outcome. It is not showing clearly either it is more or it is less. Why? It is going sometimes less than 1 and sometimes more than 1. Okay. That means if you do the study 100 times, sometimes it may show less chance, sometimes it may show more chance because the confidence interval is crossing the 1. Okay. Lower limit is less than 1 and upper limit is more than 1. In this case, whenever the case is like this, we can say it is not significant. The value, even though it is more than 1, it is not significant. I cannot say there is a more risk here. Why? The value found to be not significant. Okay. So let's see one more example. We have 0.75. The relative risk is 0.75. So 0.75 means it is less than 1. That means less chance of getting outcome. That means empirical fluorescein is having less chance of getting the mycotic infections if the value is something like this, less than 1. Okay. And we are having the confidence interval 0.53 lower limit and 0.92 upper limit. In this case, what happened? This is less than 1. Relative risk, hazard ratio, or the odds ratio, this is less than 1. And both the values, both the lower limit and upper limit, also less than 1. That means all the 95 times it is showing less than 1 only. So once again, we can say whatever value we got here is statistically significant. Why? Because this one is less than 1. Lower limit also less than 1 and upper limit also less than 1. So we can say less chance and statistically significant. Okay. So whatever I explained till now, maybe I have taken some 5 to 10 minutes to explain this one. I'll give you only 2 sentences to remember the confidence interval very clearly. Okay. What are those 2? To understand very simple way of confidence interval is, if your odds ratio, relative risk, or hazard ratio, if that value is more than 1, both the lower limit, upper limit of confidence interval also should be more than 1. If your value is less than 1, both these limits also should be less than 1. In that case, we can say it is significant. Otherwise, it is not significant. Okay, that's one way of understanding. If you want even more simpler to understand confidence interval, there's one way. Anytime, anywhere, if the confidence interval is crossing this line of 1, that means where lower limit is less than 1 and upper limit is more than 1. Anywhere, anytime, any article, if you see the confidence interval is like this, where the lower limit is less than 1 and upper limit is more than 1, you can simply say it is not significant. Whenever the confidence interval is crossing the line of 1, we can say it is not significant. Very, very simple. Okay. Hope you understand the confidence interval here. When we can say it is significant and when we can say it is not significant, because that significance is very important to take the final conclusion. And what's the final conclusion here? I can say here it is more risk. People who are taking the empirical fluorescein, they're having more chance of getting the mycotic infections. How much more? Actually, people will speak it is 3.9 times more. But being a person who understands the pharmacoepidemiology well, I can say it is not 3.9 times more chance. I can say it is only 2.9 times. Why it is only 2.9 times? Actually, the risk is, this one is a null value. As I mentioned initially, the 1 is a null value, right? Just remember clearly, understand clearly. This is a line of 1, null value, okay? And the risk is starting from 1. Actually, the risk is starting from 1. This one is a more risk, and this side is a less risk, okay? And now you can see the gap between this 1 and 3.9. So what's the gap between this 1 and 3.9? It is only 2.9. That means people who are taking the empirical, they're having 2.9 times more chance of getting the mycotic infections compared to people who are not taking the empirical fluorescein. How much? 2.9 times. That's a gap between 1 and 3.9. So if you understand this concept, how much time more risk? Can someone tell me? Here it's less risk, right? People who are taking empirical fluorescein, they're having less chance of getting the mycotic infections. Can someone tell me how much less it is? How much less chance of getting mycotic infections?
Sir, your voice was disturbed. Can you just repeat again?
Okay, so here it is 3.9, right? Whatever the value we got here is a 3.9. It is a more chance of getting the outcome. How much more means? It is the difference between 1 to 3.9. Why it is the difference between 1 to 3.9? Actually, 3.9 means it is starting from 0. If you calculate from 0 up to here, it is going to be 3.9. But actually, we should not take from 0. Why we should not take from 0? Actually, from 0 to 1, this side is a safer side, and this side is a risk side. Okay, so we need to take the gap between 1 to 3.9. So the gap between 1 to 3.9 is a 9. I can clearly give the conclusion now. People who are taking the empirical fluorescein are having 2.9 times more chance of getting the outcome compared to people who are not taking the empirical fluorescein. 2.9 times. Why? Because 3.9 minus 1, because the risk is starting from here. So I'm asking now, what's the conclusion in this case? We can say that there is a less chance of getting the outcome. 0.75 less than 1, and also both the confidence interval, both the values also less than 1. We can say there is a less chance of getting the outcome. So how much less? Can anyone tell me how much less?
0.5, sir.
How much?
0.85.
0.25.
0.25 or 0.75 or 0.85? What is the value? I can say it is I can say it is 0.25. Why? Because 0.25, as I mentioned.
0.25.
Yeah, the conclusion, we need to take the gap between 1 to the relative risk value. So the gap between 1 to the relative risk value, here it is. From here to here, the gap is 0.25. I can say that the people who are taking the empirical fluorescein are having 0.25 times less chance of getting the outcome compared to control. And if you are not convenient to say 0.25, 0.5, something like that, 3.9, 2.9 is okay, at least we can say. But if you're not preferable to say 0.5, 0.2, the 0.25 what we got here, you can convert into even percentage. The 0.25 if you convert into percentage, how much it is? 0.25 into percentage.
25%.
25%, right? So we can say that people who are taking empirical fluorescein having 25% less chance of getting the outcome compared to people who are not taking the empirical fluorescein. Very, very easy. Very easy to understand the relative risk or the odds ratio or the hazard ratio along with the confidence interval. Hope you understand this. Anyone is having any confusions, any questions on this? Because this is very, very important. Why I'm spending more time here. If you don't understand these concepts, you cannot understand the pharmacoepidemiology. You cannot read any article. The moment you see all these numbers, you may confuse or you get fear. You don't even read all these numbers. They're very simple way of understanding. Anyone?
Sir, I didn't understand how that 0.25 came.
Yeah. So what I'm saying, initially I mentioned this one line. The one is there here, right? This line of one is a null. As I mentioned, if something falls on 1, that means there is no association. From this 1, this side is less risk, and from this one, this side is more risk. If something is more than 1, it is more risk. Something is less than 1, less risk. That means everything is starting from 1. That's what I'm saying. So if something is starting from 1, the risk is starting from 1 actually, not from 0. So if it is starting from 1, the risk is starting from 1. We need to take the gap between 1 to 3.9. The gap between 1 to 3.9 is a 2.9. So we can say 2.9 times more chance of getting the outcome. And here also same, we need to take the gap between 1 to 0.75. So 1 to 0.75. So what is the gap here? The gap between 1 to 0.75 is a 0.25. So 0.25 times less chance of getting the outcome. That's what we are going to be saying. Hope you understand. Is that okay?
Yes, sir. Thank you, sir.
So always, it's very simple. If you don't understand all this concept, very simple. If you want to conclude finally, you can do one thing. Whatever the value you got, do -1. 3.9 -1, that much risk it is. 0.75 -1. Don't bother about the minus value. 0.75 -1, you're going to be getting 0.25. Okay. So you can just do -1 and then go for the conclusion. That's it. Very simple. So now we'll go here. Can someone tell me one by one? I think without wasting time, I can only explain to you. So 3.93, it is more than 1. So we can say more risk. And confidence interval, both these values also more than 1. Lower limit is more than 1, upper limit more than 1. We can say that's a more risk. And p-value, the p-value should be less than 0.05 to say it is significant. So the p-value less than 0.05, because p-value here it is less than 0.001, it is less than 0.005, less than 0.05. So we can say it is significant once again. So because we got the more than 1 value, and also it is found to be significant based on the confidence interval and the p-value, we can give this conclusion. So what's the conclusion here? People who received empagliflozin had 3 times more risk of developing the female genital mycotic infections compared to placebo. So why it is 3 times? It is 2.93 times. Approximately, it is going to be 3 times. That's what the conclusion, exact conclusion we should be getting. Okay. People who received empagliflozin had 3 times more risk of getting the female genital mycotic infections compared to placebo, or maybe compared to other anti-diabetic medications. So still anyone is having any confusion here? Anyone?
Hello, sir.
Anyone's having any confusion? Anyone?
Yes, sir. How can we set that upper limit and lower limit, sir?
Yeah, that's what is the confidence interval. Actually, there is a formula to calculate this confidence interval. Always when we calculate relative risk, we need to calculate the confidence interval. There is a formula for that. I did not show that formula here. Why? Because it's a big formula. And if you don't know how to calculate the confidence interval, no problem, no issue. Don't bother. Why? Because nowadays we are having so many calculators. Online calculators are there. SPSS has so many softwares are there. If you just enter these 4 values, A, B, C, D values, you're going to get your relative risk, confidence interval, and the p-value. You will get it, no problem, from anywhere. But only thing is you should be knowing how to interpret. That's why I focused more on interpretation than the calculation. I'm not a biostatistician, so that's why I did not show you all the formula and all. So once you get the value, how to interpret, how to understand the confidence interval, that's what I explained. So in the confidence interval, we are going to have always 2 limits, upper limit, lower limit, and upper limit. The lower limit is always going to be less than this value. Upper limit always going to be more than this value. Very simple.
Thank you, sir.
Is that clear?
Yes, sir.
Yeah. So still, anyone is having any question? Okay, then we can go for the few more slides, and then we can have more questions. So this one is a case control study. You can see here how it's different from the picture of cohort study. In the cohort study, we started here, and the time is going like this, right? But in a case control study, we started here, and the time is going backward. We are starting the study here, and the time is going backward. Okay, and you can see at present, when we start the study, we are going to be having the study population. What are the study population? We're having the cases and the controls. Cases means who are having the disease. Controls means who are not having the disease. And then we are going to be inquiring about the past history. Hello?
Sir, I'm sorry to interrupt, but your screen has frozen, I think.
I don't know what's the problem. The problem for everyone? You cannot see my screen?
Yes, sir. We are not.
Sir.
I'll reshare it once again. Yeah. Can you see my screen now? Can you please confirm?
No, sir.
No, sir. No, sir.
No, sir.
Okay.
That might be poor internet connection, sir.
Let me change my internet connection. I'll try. already 9:15 around. I'll just take 5 more minutes. Okay, I'll just finish it. So maybe I can have one more class. Now you can able to see my screen. Can you
Yes, sir.
okay.
Yes,
Yes,
sir.
sir.
Okay, you can able to see my screen. Now, this is what is going to happen in case control study. We are going to have the study population, and we are going to have two groups, cases and controls, right? Cases means who are having the disease, and controls means who are not having the disease. And then we are going to be inquire about their past history. And in the past, we are going to be understand among the cases, how many are already having the exposure and how many are not having the exposure. At the same time, controls, how many are having the exposure and how many are not having the exposure. Okay. So at present, we are having the information on the outcome. And if you go and inquire the past, we are going to get the information on exposure. And we need to remember, we are going backward. Okay. From today, we are going backward. That's why we can call it as a retrospective study. Case control study is a retrospective in nature. Quickly, I'll explain to you this example, this calculation. The same like empirical flows in only, but here the outcome is UTI. And what we are going to be do, because it's a case control study, what we are going to be do is, we are going to be take two groups initially. What are those two groups? One group is people who are having the UTI, another group people who are not having the UTI. These are the two groups I'm taking now, UTI and non-UTI. And I'm going to inquire about among this UTI, how many are already having the exposure of empirical fluorescent, how many are receiving other medications. Okay, out of 243, 167 receiving empirical fluorescent and 76 receiving other medication. And out of this 2728 who are not having UTI, when you go and inquire, we got to know, for example, 1809 receiving empirical fluorescent and 919 receiving other anti-diabetic medication. Okay, what we did here, we have taken the cases and controls who are having the outcome, who are not having the outcome, and then gone back and inquired about the exposure status, how many are having the exposure of empirical fluorescent and how many are not having. That's what we are doing. And we have given once again the same coding, ABCD. And for this, we are going to be calculate the odds ratio. Odds ratio we are calculating for the case control study. Once again, very simple formula, A by B divided by C by D. A by B divided by C by D. So what is meant by this A by B divided by C by D is A by B is a odds of outcome in the exposure group. C by D is a odds of outcome in the non-exposure group. Very simple way. Or we can also write this formula in another way, AD by BC, cross multiplication, AD divided by BC. We can simply do that. Okay. Can someone tell me quickly, can calculate and then tell me what's the value you got? AD by BC, A into D divided by B into C. If you have these values, so 167 into 919 and 1809 into 76. And you're going to be have these values. And finally, we are having this odds ratio. Odds ratio is 1.12. And confidence interval is 0.84 is a lower limit and 1.48 is upper limit. And p-value is 0.478. So based on the explanation I have given how to understand this previously about relative risk, can someone tell me what's the conclusion from this analysis? Odds ratio is
statistically insignificant.
Exactly. So before going to this one, we can go one by one. Okay. So how we can go one by one? First, we can see odds ratio. What is odds ratio? 1.12. So it is more than 1. So more than 1 means actually more risk. Actually more risk. But what happened here in the confidence interval, one value is lower, less than 1.84, and one value is more than 1. That is 1.48. So it can tell us, even though we got this one is more than 1, but it is found to be statistically not significant. Okay, statistically not significant. And at the same time, even the p-value telling us that this value is not significant. Why? Because the p-value is more than 0.05. More than 0.05 because the p-value is 0.478. So both are giving same information. Both are telling that this value found to be not significant. So because it is not significant, I cannot give the conclusion of more risk, that is around 0.12 times more risk. I cannot give that conclusion. Whenever something is like this, whenever something is not significant, usually the conclusion is going to be like this. There is no significant association identified between the empirical fluorescent and UTI. whenever something is not significant, we cannot say that there is a more risk or there is a less risk, whatever the value it may be. Your value of odds ratio, related risk, hazard ratio, whatever it may be, we cannot say that there is a more risk or less risk. We are going to be simply say that it is not found to be significant, or the association is not there. No significant association identified between the exposure and outcome. Okay. So I would like to end here because of time constraint. Actually, I'm having some more slides, especially on randomized control trial. Maybe I can take one more lecture on this randomized control trial. I can give you more information. At least if you understand whatever I explained till now, I'll be very happy. And maybe I can take it up now. If you have any questions, then maybe we can conclude. We have another 10 minutes for 9:30. At least we can stop by 9:30. So anyone is having any questions, we can discuss further.
Yeah, thank you, sir. I remember my 5th year days now. So I think I read all this from Patrick Malone textbook.
Yes.
Which gave me much good understanding. So it was very interesting, and we will do one more, sir. We will do one more.
Yeah, sure,
so
certainly. I want to have one more at least to explain, especially the randomized control trial, where we are going to be doing more calculation and will be more interesting, because we are going to be calculate relative risk reduction, absolute risk reduction, number needed to treat. There are so many.
Yes.
There are so many. Very interesting they will be, like, actually. So because of time constraint, I'm not going in further. And that too, if I teach all those things at a time, it may be confusing for you. So I'll stop it here. If you have any questions, we can discuss, and then maybe we can have one more whenever possible.
Sure, sir. So soon we will have. So participants, any question? If not question, feedback. Like, what did you feel?
Sir, can you please continue the session? So I think still some people are very interested to continue. I'll certainly continue. I don't want to stop. I don't want to stop this discussion here. I'll certainly continue, because I know I should understand the feeling of others also, because 9:30 and that's on Saturday.
And so actually, sir, I have dinner early. So I finished my dinner. I don't know if you had dinner or other participants had. So we will do again, definitely. And as sir said, there are more calculations in RCT. So you can watch this video again, become familiar with these concepts, and we will do one more definitely. So I want to hear any feedback. So how did you like this session? Did you understand? Did you get more clarity than the previous time you learned these concepts? Anybody can unmute and speak.
Sir, can I speak up?
Yeah, I must.
Yeah. So actually, this was very interesting session, sir, because what we studied in 4th year, even biostatistics starting, we had these topics, but it was online sessions they were there, so we could not completely catch up the basics. So after what Krishna Andala sir have explained, I understood one thing, that this subject needs a strong basics and a very good background of sound understanding of all the perspectives of the study designs. And it was very good understanding when I studied all those confidence intervals and statistical significance. I actually didn't understand. We had to search up internet statistics how-to.com and all to understand these concepts. But now it actually got cleared, and now clearly understand what all these are. And thank you so much, sir, for taking up this class.
So Alvin, you can stop the live stream. So Krishna sir, actually when we read biostats, so all we learned was calculation. Like